Now, you can introduce yourself in the chat. Today's class will be focused on what to know before the 2CK exam. You can use this class to have a rapid review just before the exam. This is going to be one of the first class in a series meant to help you review in the last, let's say, 3 days before the exam. Yet? So there is a 35-year-old patient that had a vehicle accident. He comes to the ED where apparently he looks well. He has some abdominal tenderness. His vitals show 80/40. Also blood pressure of 120. A heart rate. And a temperature of 37 degrees Celsius. Now he has no apparent bleeding. And the question is, what is the best next step? A. Do we do a peritoneal lavage? B. Do we go for a fast scan? C. We do a CT scan? Or D. We already go for emergency laparotomy? Okay, let me know your answer in the chat box. Okay. Practically on step 2CK for the surgery section there will always be an emergency section. In this case, it is the algorithm of blunt abdominal trauma. We have two options when talking about blunt abdominal trauma: hemodynamic stable patients and hemodynamic unstable patients. The hemodynamic stable patients will undergo a CT scan, as in this case C. On the other hand, patients that are hemodynamically unstable, such as this one, will go for the fast scan. If the fast scan is unequivocal, then we consider a peritoneal lavage. Emergency laparotomy has one indication, and namely not abdominal tenderness but abdominal rigidity or surgical abdomen. Okay, so to have a comprehensive view of what I've talked before, this is the algorithm that might get tested in the surgical section. Blunt abdominal trauma, then we have to think, is the patient hemodynamically stable or unstable, meaning we just go at the vitals in the vignette. If he is stable, we directly jump to the CT scan. If he is unstable, we go for the fast scan, but we screen the vignette because some of them will tell you that the fast scan does not show anything. And in this case, it means that it is uncertain and we can go for a peritoneal lavage. Okay. Are there any questions on the topic? Okay, since there are no other questions, we will go to the next question. In this case, we have a 32-year-old female that comes for routine pre-work screening. On the clinical exam, there is a lump in her throat. And on the labs, we have a TSH that amounts to 0.1 international units per liter. Okay. Now, she has no symptoms. And the question is, what is the next step? We dose T3 or T4. We perform a fine needle aspiration. We perform a rhioscan, or we do an ultrasound. Let me know your answer in the description. So we have D, indeed Marcelo. Lucas also says ultrasound. Yes, indeed. We are going for an ultrasound. For the medical part of Step 2CK, especially for endocrinology, we will have questions on the thyroid function. The algorithm for diagnosing hot and cold nodules differs. When examining the thyroid, we firstly look on clinical findings such as lumps, nodules. A good rule of thumb is everything that is greater than 2 centimeters has an indication of ultrasound. Also, everything that has more than 1 centimeter with symptoms also requires ultrasound. After we have these clinical findings, we go for the TSH. We dose the TSH. Sometimes, if there are symptoms of hyperthyroidism, or if we suspect Graves' disease, we will also take note of the T3 and T4 on the labs. The next step is indeed, as we saw in this question, to perform the ultrasound. The ultrasound can be doubled by the rhioscan. The rhioscan will identify if the nodules are hot or cold. Very importantly, cold nodules need fine needle aspiration as they can be malignant. If the nodule is hot, then indeed we can suspect, for instance, toxic adenoma. However, hot nodules will never require fine needle aspiration. To cement this algorithm, let's go a bit through it. So, yes, we should talk about this in a minute. For a thyroid nodule, we firstly palpate. If clinically it has irregular margins, or if it is firm, we suspect malignancy. Yes, indeed, we have, even in a clinical setting, to describe it: irregular margins, mobile or firm, simple or multiples. Then as we discussed, we see on the labs the TSH, which is low in hyperthyroidism and high in hypothyroidism. The TSH is followed then by T3 and T4, and the ultrasound is especially useful to screen for signs of malignancy, such as intranodular calcifications or irregular margins. Now, we have the last step that is represented by scintigraphy, as we discussed before, with hot and cold nodules. And the cold nodules, as they can be malignant, they require FNA. Are there any questions on the topic? Okay, since there are no questions, we will take a break, and I will leave a link in the chat box with the part 2 of this presentation. This part 2 will take place next week, and here you'll have some questions to test yourself on them, on the concepts. A 6-year-old male presents with hair at the level of the axilla and also at the inguinal level. Now, his LH FCH is high. So he undergoes an MRI that shows nothing. Let me see if I can... Okay, that's better. The MRI shows nothing. Then what is the diagnosis? We have an adrenal tumor. Maybe he has a pituitary tumor. Also, we might consider Leydig tumor, or he has idiopathic precocious puberty. Let me know your answer either in the description if you're rewatching it, or in the comments. Okay, so the right answer is actually D, idiopathic precocious puberty. If the patient would have had an adrenal tumor due to the secretion of DHEAS and of actual testosterone, the LH and the FCH would have been low. If the patient has a pituitary tumor, then indeed the LH and FCH is high. However, on the MRI we will see the pituitary tumor. In the case of Leydig tumor, once again, there will be peripheral production of hormones which will blunt the hypothalamic pituitary axis, leading to low levels of LH and FCH. Let's review a bit the algorithm to think about precocious puberty causes. So there are two types of causes, central and peripheral. Every time we have a question on precocious puberty, the first step we take is to determine the LH and FSH levels. If the LH and FSH levels are low, then this means that the hypothalamic pituitary axis is shut down. This translates into peripheral causes. Some peripheral causes of precocious puberty are adrenal adenoma. In the case of adrenal adenoma, a good marker on the labs will be the DHAS, which is made only in the adrenals. Otherwise, we can have adnexal or testicular tumors. Or lastly, we can have exogenous administration of testosterone and estrogen. We can see these in the clinical vignettes with athletes. There might be females that are actually muscular, or they might be cyclists. Usually in the clinical vignettes, it is stated that they are aggressive. On the other arm of the algorithm, we think of the cases when the LH-FSH levels are high. This happens with central precocious puberty, when we can have a pituitary tumor that secretes LH and FSH, or a hypothalamic tumor that secretes GnRH. Nevertheless, the other possibility is the idiopathic precocious puberty. In the case of the idiopathic precocious puberty, the MRI is negative, as in our case. Please remember the fact that precocious puberty means that the male has secondary characteristics at less than 8 years old, or that the female has secondary characteristics at less than 9 years old. Let me know in the chat or in the comments if you have any questions on the central versus peripheral precocious puberty algorithm. So no questions here. Great. Let's do the last high yield algorithm for 2CK. Okay. Now this is an interesting one, and it is one of those questions that might make the difference between top performers and a good score only at 2CK. We have a 26-year-old female. She has a breast lump in the right upper quadrant. Interestingly enough, it is firm. What is the initial step for her? We are doing a mammography. We are doing a core needle biopsy. We are performing an ultrasound, or we do an excision followed by biopsy. Let me know your answer either in the comments or in the chat box. So we have an ultrasound. Okay, Marcelo, really good, really good. Yes, indeed, the answer is C, an ultrasound. This is a very short and sweet algorithm that the NBME loves for patients who have less than 30 years old. The density of the breast is too low therefore, we consider ultrasound to mammography. The patient who has more than 40 years old is prescribed a mammography. There is the case of choosing between ultrasound or mammography if the patient has between 30 and 40 years old. Okay, let's just recap a bit. So for breast cancer, we have a palpable mass. Under 30 years, we go for ultrasound. More than 30-40 years, we go for mammography. And then mass excision and biopsy. Okay, now we have an additional part of this presentation. It is represented by how do we approach drug ads. Drug ads are usually long-winded. They might take a lot of time to read entirely, so we do not read them entirely. They are in sequence, meaning that there are usually 3 questions. There might be 2 questions, but rarely. And the gist to them is to know how to approach them rather than how to solve them. The solution is already there. Firstly, we read only the question, meaning the last sentence. You will be asked, for example, if the patient might benefit from the drug. And you will have a lot of data on the drug ad. So you have to look for significant classes. For instance, you will have an efficiency for diabetic patients, an efficiency for patients with heart failure. You do not go yet to those sections. You do not look on that information. You have to restrict all your information gathering to maximum 5 elements. So the first element is the question. For instance, in this case, would the patient benefit from the drug, let's say. Then you go to the class the patient might be. So you go at the start of the vignette and you skim for the enumeration of his medical history, heart failure, diabetes, etc., etc. Once you got those underlined, you go and look on the drug ads at the classes, and you'll see heart failure, but maybe you won't see diabetes. So you go to heart failure and you look for significance, so P value under 0.05, or you might have a relative risk. In the case of the relative risk, you want to have a confidence interval that actually does not include 1, and if you want to be beneficial, it has to be below 1, and if you want to demonstrate that it's a risk for the patient, you have the relative risk above 1, but not including 1. The same for odds ratio. Okay, as I told you before, you have to skim the patient's presentation to align her conditions with ones on the ad. Shortcut with some of the high-yield algorithms that we will cover next time. Let me know if you have any suggestions right now in the chat box, or if you're rewatching it in the comments. And I'm looking forward to seeing you on the next one. Also, Marcelo and Lucas, thank you for the active participation in the chat. Okay. Have a nice day ahead.